and myself then?
Yep, looks that
Great.
way.
Let's get started then.
Okay.
All right.
Hi, everybody. My name is Deb Behan. I'm a volunteer with KidneyCAN, and Dr. Tannir has graciously invited some experts in the field of subset variant RCC, and we're very interested in the talk. I do ask you, if you're an audience member, if you could have yourself muted and your video off until the panel discussion has concluded, and then we'll have plenty of time to do questions and answers. And if you do have any questions, please put those through in the chat. And Dr. Tannir will be watching that as well as the other doctors, and we'll get those questions answered as fast as we can. Now, if you are not here for the variant subset RCC discussion, watch the chat, and Helen will be putting the information for that subset chat room to open up. And if you wanted to, you can just follow that instructions and move on over there. So I thank everybody for joining us. I know it's late at night for some of our experts in the field in France, and I'm gonna give this over to Dr. Tannir. Thank you very much.
Thank you, Deb. I appreciate the help. I would like to thank you and thank Ms. Helen Porter for the logistic help and the organization of this. It's a pleasure and a privilege, an honor to be with you all, to have a live and lively, hopefully, productive discussion and exchange among our colleagues about these rare subtypes of kidney cancer. First, I just in the 1 or 2 minutes want to thank our French colleagues who are up at 1:30 in the morning in Paris time to be on this call. And I want to thank all the other colleagues. And just to take a minute to go around and introduce each other. I'm Nizar Tannir. I'm a professor and at MD Anderson Cancer Center. I am founder and president of the RMC Alliance. And with me tonight is Professor Stéphane OUDARD from Université Descartes Paris 5 in Paris, and he is chef de service at Hôpital Pompidou. Also, Dr. Gabriel Malouf from France. He's a professor at University of Strasbourg. I think Dr. Ram Srinivasan. Ram, are you there? He said he was a little bit late dealing with a patient issue. Dr. Srinivasan is investigator and head of molecular cancer section at the NCI. Dr. Roberto Pili is with us, and glad he is able to join. He's recently moved from Indiana University to University of Buffalo in Buffalo, New York. He is Associate Dean for Cancer Research and Integrative Oncology and Chief of Hematology Oncology and Professor of Medicine at University of Buffalo. He's Director of Center for Nutritional Sciences and Cancer Therapeutics at University of Buffalo. With us tonight, Dr. Pavlos Misaoul is my colleague at MD Anderson. He's assistant professor. And with us also Dr. Jim Geller. He's professor of pediatrics at Children's Hospital in Cincinnati, and is also medical director of both kidney and liver program at Cincinnati Children's Hospital. Dr. Mehdi Mollapour is with us. He's professor of urology and vice chair of translational research and director of the kidney cancer program at sunny upstate Medical University in New York. And with us also Dr. Brian Shook, who is associate professor of urology and director of the kidney cancer program at UCLA. And also, last but not least, Dr. Lisa Henske. Dr. Elizabeth Henske is professor of medicine at Harvard Medical School and director of the Center for LAM Research and Clinical Care. And also, she is a medical oncologist at Dana-Farber Cancer Institute in the Lank Center for Geomalignancies. I believe we have everybody, and we'll get started. First, again, we'll start with Professor Stéphane OUDARD. Question for you. You have been doing research on collecting duct carcinoma or Bellini's tumor. I'd like to ask you to briefly, in maybe a minute or two, speak about where we stand with the diagnosis of this disease. Sometimes I think in the US, pathologists really are not willing to commit to the diagnosis of CDC, and they call it CDC, possibly papillary type 2, possibly unclassified. Whereas our French colleagues, the pathologists, are more committed or brave to make that diagnosis. So how is that possible there? And then what's the latest, molecular understanding or underpinnings of CDC? And then I know you have published on trials, and you do have now, you are developing some trials for CDC. So take us, Stéphane, please, through those questions, if possible, in the next few minutes, please.
Thank you very much, Nizar. So first of all, it's a rare tumor. It's about 1% of all kidney cancer. It has been recognized as a separate histology entity in 1986, and it was originated from the renal medulla, and it shares some common characteristic with urothelial carcinoma. And in looking at their histology, it's sometimes difficult to distinguish from renal medullary carcinoma. As you know, we have some two CR database which show that for those patients, they are mainly male with an aggressive disease, a median OS of less than 1 year. And there is an interesting study from Montipal looking at genomic alteration, specifically on 17 CDC, metastatic CDC, and it showed that looking at the FFPE slide by DNA extraction, looking at genomic profile, that we have some frequent genomic alteration, mostly NF2, ZD2, SMART CB1, and CDKN2A, and additional genomic alteration. And we know also that we have some FH homogeneous loss in around 20% of the patient, which may drive to putative strategy. Based on that, we have a very nice paper from Gabriel, and thank you, Gabriel, for this really interesting data from transcriptomic analysis regarding CDC relative to upper tract urothelial carcinoma and also non-clear cell carcinoma. And it was shown that by Gabriel that CDC display a unique transcriptomic signature, and CDC is characterized by metabolic shift with the impairment of oxidoreductase activity and pyruvate metabolism. And also in this study showed that you have an increased tumor infiltration lymphocytes, particularly in metastatic sites. So based on that, as you know, we have the Tannir study based on PD-L1 expression regarding CDC. Very few patients, in fact, 5 patients, but when he looked at the absence of PD-L1 positivity based on more than 5% tumor cells membrane staining, he found that 20% of PD-L1 expression in tumor cells membrane and 100% of tumor infiltrating mononuclear cells. So based on that, few case report on nivolumab, we have the French study looking at the AXE program regarding nivolumab, especially in Bellini tumors. So the study is not yet closed for the inclusion. So we may have around maybe 25 to 30% of objective response. As you know, looking at immunotherapy, TKI or mTOR emitter, the objective response was almost 0 based on, a study from Nazir, from Bob Moser, and from Martin Voss. And looking at chemotherapy, we performed a study a long time ago, 13 years ago, looking at gemcitabine plus cisplatin salt drug on 23 metastatic CDC, homogeneous patient based on the central pathologic review. And we found on those patient population an objective response of 26%, 1 CR, 5 PR, a clinical benefit of 70%, which is not too bad, and median PFS of 7.1 months on median OS of around 1 year. So based on that, we wanted to add on the top of chemotherapy bevacizumab based on the study in bladder cancer. So we proposed to 5 patients, the addition of beva plus chemotherapy, gemcitabine plus platinum salt, and we found out that we had almost 5 patients having response, on the 5 patients who were treated so far with a good median PFS and a good OS. So that was the basis of the Bevavel study, which was presented at the ESMO meeting, a few weeks ago. So around 34 patients, mainly CDC. We had very few patients having renal medullary carcinoma, and we proposed chemotherapy with bevacizumab with the maintenance of bevacizumab. So I can show you the data. It's around the patient characteristic were, as usual, in CDC. And the primary endpoint was looking at progression-free survival at 6 months and objective response rate at 6 months. And the duration of therapy is around 6 months. The objective response rate at 6 months was around 30%, and we had 1 complete response and 12 partial response. So the PFS at 6 months was around 40%, and the median OS was around 1 year. But we were surprised that the fact that for these regimens, we had some toxicity regarding bevacizumab, and 1 patient dying from encephalopathy, maybe due to the disease, maybe due to the treatment related to the treatment. Based on that, we performed also another study, a retrospective study that we published at the ESMO meeting a few weeks ago about the Sequoia trial. So we took into account patients from a decade in France having CDC, metastatic CDC, and we look at those patients having chemotherapy at first and then secondary treatment. And we found out that for those patients having either TKI, immunotherapy drugs, or chemotherapy in second line, the response rate ranged from 10% to 15%. So really, we need to have new treatments so far to go further. So as you know, we have some phase 2 trials so far. One study with cabozantinib, the Bonsai study performed in Italy. We have also one study in France, the ACCESS program with nivolumab. And we have also a phase 3 study with atezolizumab so far, but we don't have yet the data. In France, we have conducted 2 studies. One has been, in fact, not received by Merck. We received a negative response from Merck regarding the Pembrolizumab study, trying to find out how to combine chemotherapy with pembrolizumab. But, so far it's difficult to convince Merck to go for this, study. So we were quite disappointed by the fact that we had a negative answer. And right now we are on the good way to convince Pfizer to go for the BELA study, Bellini avelumab study, based on the data that we have in the Javelin study, to perform chemotherapy, and then for patients having clinical benefit to go for avelumab so far. So based on that, it's open for discussion.
Thank you, Stéphane, for your tour de force, as they say, on this topic of therapy. But I think, is it fair to say that at this time, we really have not moved the needle much to improve the outcome of patients with metastatic Bellini, that unfortunately, most of the patients with metastatic collecting duct carcinoma or Bellini's tumor, unfortunately, succumb to their cancer with a median survival of a little over a year. I think despite adding bevacizumab or other target agents to cytotoxic chemotherapy that's platinum-based, and now we're exploring the benefit of immune checkpoint inhibitors, either as maintenance strategy, like we said, similar to bladder, having avelumab later after chemotherapy, or in combination, or by itself alone. We really still have not moved the needle forward, which really brings up the importance of really doing research on these rare tumors, which is what this whole forum is about, is to try to brainstorm how can we advance the field of really biology to really understand beyond just cataloging, some of the molecular alterations or genomic mutations in like you mentioned, CDKN2A or NRF2, which are really, or SEPT2, etc., common among other tumor types, which we will discuss. Thank you very much for, again, this Tour de France. I want to tour de force and Tour de France. Tour de France, we'll talk to Gabby next. Gabby, this is another, disease we'll talk about now next with yourself and Jim and Roberto, a disease that is also near and dear to my heart for many years. You know, this is translocation renal cell carcinoma. So Gabby, I hope to see your face, Gabby, but are you there?
Yes.
Okay. Thank you for opening your video. So take us, give us, if you want, an overview, the 30,000 bird view of what we know about translocation. You've done a lot of work on this, and you still do, and that's obviously now since you moved to Strasbourg. Tell us, what is the latest that we know about TFE3 and TFEB in terms of biology? How has our understanding moved from a few years ago when we published together the two papers in CCR about, the novel partners of TFE, TFE3, and then the mutations. And then I'll ask you after, you in the next segment of your piece about translocation, what are the therapies that you think patients, who are listening here tonight or later will watch the video, what can we tell them about the therapy for translocation outside the context of a clinical trial? Of course, if they do not have a clinical trial on for translocation, what is the best treatment right now that you would recommend for either an adolescent or a young adult with metastatic translocation?
Thank you so much, Nizar, for the kind invitation and for the questions regarding translocation renal cell carcinoma, which basically represent around 1 to 6% among all kidney tumors. So it depends basically if the pathologists look basically for the translocation. And this is something very important because initially the defining feature of the disease was the translocation of TFE3 and then TFEB. And we realized that, from time to time, we have translocations also for MITF. And recently, we have also a family with the FEB amplification. So the family is really expanding. And since, our initial publications, I think there has been some efforts done by our colleagues also from Memorial at Resnick, showing also and confirming what we have previously shown, that translocation RCC are tumors associated with the translocation, but with very low mutational burden. So the mutation burden is really very low in these types of tumor, and they are associated so far with at least for TFE3, 16 partners. For TFEB, we have now 2 partners. And the big question is whether each partner is associated with some specific, basically, molecular features. So we know from some reports, the pathology, that whenever you have no TFE3 or whenever you have ASPS CR1 TFE3, we have very specific features in the pathology. And the big questions is whether from molecular feature or from immune like landscape, is it different between these types of tumors? So this has been something that has not been resolved, and I think this necessitates future efforts. And in particular, we are currently trying to generate 2 or 3 models with different fusion partners to better understand if the partners of TFE3 or TFEB can be associated with different aggressiveness of the natural history or different response to treatment. So I think this is where we are going so far. And finally, to comment on the effort that has been done by our colleague in Memorial Sloan Kettering in the recent paper in CCR, they found that these tumors have a specific immune feature and angiogenesis features. However, the response to agents in used for clear cell RCC are not very, very important nowadays. So now I would like to answer your second question, whether we have really specific drugs that we can recommend in this setting, of course, outside clinical trials. So first, I would like to strengthen the fact that we need first to understand the biology to come up with specific drugs for these types of tumor. Second, that the field has evolved since the first publication, basically, where you have done also with Tony Schwery in 2010. We published a paper with Bernard Escudier, is that 2010, we were thinking at that time that the FE3 by IHC was enough to say that these are translocation RCC. And I think these were the first publications by Dr. Argani, and we realized over time that we have some types of clear cell RCC or papillary RCCs that overexpress the FE3 without translocation. So thus the first reports were about the response to VEGF TKI and showed a PFS around 7 months or 9 months for VEGF TKI. And in the recent cohort that we report last year, with the help of many colleagues present here today, we showed that the median PFS on VEGF TKI was around 2 months. So all the patient has been confirmed by FISH. So these patients are primarily resistant to VEGF TKI, and the same basically effort we looked for the response for immune checkpoint inhibitors. The majority of the patients has been treated by monotherapy. Nivolumab second line, very few patients treated first line. And again, the response rate was really very low, around 16%, suggesting that these patients do not respond very well to immune checkpoint inhibitors, with some patients presenting some hyperprogressive, basically, disease. And nowadays, we do not have a lot of data about combination therapy, whether combining basically TKI with nivolumab or nivo with ipi leads to better outcome. And recently we have done some work where we are collecting some data on the efficacy of cabozantinib in this setting, because there has been some preliminary data by several people showing that the FE3 might bind to c-Met and overexpress c-Met. And the primary data that we are having, I mean, still the cohort is very limited, is suggesting that, you know, these patients might respond to these types of agent. I mean, the efficacy looks to be better than usual, you know, VEGF TKI. However, I think we need to collect more data. We need to collect more data on combination of these types of agents with immune checkpoint inhibitors. And we need to better understand the biology of the disease to be able to come with a real hypothesis with drugs that are specific to these types of tumors.
Thanks, Gabi. I think I feel like the field is moving forward with the biology, with understanding the biology. Hopefully, with the mouse models you're developing there with your colleagues at University of Strasbourg, that can help us do some co-clinical trials where you can test this in the mouse models and then maybe do a clinical trial that is really biology driven. So I want to turn to Jim. Jim, you have been really working also on translocation, and I know you and Ram. I hope Ram has joined us. I don't know if you're there, Ram. He had a patient issue, but
I'm here.
Great,
I'm here.
great.
Ram's
here. I know that Jim and Ram really worked hard to organize a conference about translocation in Cincinnati in the past spring, but of course the pandemic came and this was canceled. Hopefully next year you'll do that. So Jim, I know you've been working with the Children Oncology Group. You're vice chair of the renal renal program at, or a tumor program at Children Oncology Group. Take us, if you will, through your efforts with COG as well as at Children's in Cincinnati. What have you advanced your translational research in translocation? Because obviously the disease is, we know the disease in younger people, especially children and young adolescents, may be more indolent. So it has a different biology than adults with translocation. What have you so far done in terms of translation research? And I know you've been working on a clinical trial combining immune checkpoint inhibitor plus TKI.
Yeah, so 3 points to point out for the group, and I'll try and be brief for time. We do have a national biobanking study that enrolls all cases, and we have biomarker work on about 200 cases. About 90 are TFE-RCC. We have the genomics. We agree that there's no real mutations, and we have some RNA. We also have a need for tumor models for drug discovery through the PPTC. Please tell me if you have any models. And lastly, the AREN 1721 protocol is open to patients of all age groups through COG, ECOG, SWOG, and Alliance, studying Nivo versus Nivo-Axi. And we don't know whether PD-1 inhibitors work. We do encourage enrollment. I think people feel that everybody should get a PD-1 inhibitor and everyone should get a VEGF inhibitor. And I would ask this community to consider the fact that we don't have a good standard of care, as Gabby pointed out. I will suggest to you that the reasons I've heard for people not wanting to enroll on AREN 1721, and I rushed to this topic intentionally, but I'm happy to go back, is because we worked really hard. In fact, it was 8 years ago, Nizar, when you and I chatted at a KCA meeting, where I presented the pediatric TFE-RCC data and said, we've got to study this together. And at the time, it was all about third generation TKIs, and we advanced to phase 1 with Pfizer with axitinib and got it done. And in developing a phase 2 for TFE-RCC, lessons were learned where it took time to create that study. And in the time of creating a phase 2 AXI study, the PD-1 inhibitors emerged. And there wasn't an appetite to have a study without them. So we had to modify. We first got Merck, and then BMS joined us for the trial. And lo and behold, in 2018, 6 years later, we opened a trial that's opened at all COG study sites. It's open, available through the NCTN, so everybody on this call can access it through ECOG, SWOG, or Alliance. And it's important that we enroll. We had some poor enrollments at first, and there were a few issues that Gabby alluded to, one being diagnostics. TFE-RCC, unlike some of the other variants you're going to hear about tonight, they can mimic the appearance of clear cell and papillary on a histological review. And for patients who are less than 40 or even less than 50, those rates of TFE positivity are even higher than what Gabby suggested. In children, 48% of all RCC are TFE type. So I think one of the challenges is diagnosing these patients, and we need to encourage our pathologists to do so. The second challenge is getting the patients on study, because Nizar, as you pointed out, to enhance funding, awareness, visibility, these conferences are important, but to enhance clinical insight and to benchmark this disease, to prove that we can study this as a group collaboratively, we need to enroll. And I've heard people say, well, AXI, Pembro, or combination VEGF, PD-1 is the standard of care for all RCC. That should not be the case. The last 21-year-old I treated this past year with TFE-RCC developed grade 3 bordering on 4 colitis and was in the hospital for weeks on end. We know that these drugs are not without side effects, and to just assume that they're active, I think, is a mistake. So what I would encourage is that there is the available study, AREN 1721, through the various cooperative groups. It is open and accruing now. I know Ram is working on considering whether it could be available at the NCI, and other centers have it available. I know it's available at MD Anderson through Dr. Daw and other centers. Please consider enrolling. There are endpoints that characterize the disease over time. We are allowed to collect some data, and there's also enhancement of collection of a biobank. So I'm going to share the translational genomics work and the RNA work as soon as I can get my bioinformatics doc to sign it out, because I want you all to have access to the data. We have whole genomes on 24, 25 cases, and RNA and methylomes on another 45. And there are some insights there for all of you, and I want it in your hands. Secondly, the tumor models, please, we have an application going in as the Pediatric Clinical Testing Consortium is in its recompete. And we're hoping to include TFE-RCC in the renal submission, which means those xenografts will get tested by about 12 different drugs every year in negotiation between CTEP and pharmacy. And then third, the clinical trial and the biology. It's all there for us to learn together. So Nizar, I rushed through a lot of ideas because I was anxious to talk about the trial, and I thank you for the opportunity and hope that people will consider it and working together. So thank you.
Thank you, Jim. I'm, as you know, supportive 100%. I think, this trial is important, I mean, obviously from the therapeutic standpoint, but also to collect all the tissue in an annotated way. And I think to answer the question, with the contribution of these different classes of agents in translocation, let me ask you, are you requiring before patients enroll that they'll get FISH positive test before, so that that this is, or RNA-seq before they get on the trial to make sure that this is a confirmed translocation?
So the process as written requires a typical morphology, which obviously has overlap, and at least strong immunohistochemical expression that is nuclear for TFE3 or TFE-B. There is an embedded central review process that is retrospective, overseen by Dr. Perlman, in agreement with the pathologist from ECOG. The FISH is not required. The characterization of all the biobank cell lines that I discussed before did undergo FISH and or Archer and have confirmed translocations. But that confirmation of cytogenetic translocation is not necessarily required. It will be done on the back end, but not for enrollment and initiation of treatment.
Fantastic. I think we can talk about questions later.
Sure.
I get some questions here now through the chat. Roberto, turning to you now. Obviously, we're still talking about translocation here. You've done some work there when you were at IU and published this in CCR last year. Can you tell us a little bit about how you a follow-up on that publication? I think you were focusing there. You had a cell line, and you did some work and found that the PI3 kinase AKT mTOR pathway was relevant in this disease. Although, clinically, we've seen some patients respond, of course, to mTOR inhibitors, but not the what you would say this is a unusual or outstanding response. Can you tell us a little bit about the work? Have you moved forward with this to take it to the next level?
Thank you, Nizar. I'll try to be brief. And I want to commend actually Jim and Gabriel Ram and all the work they're doing, especially Jim about the clinical trials. That is, we need a champion like you for this very sad disease. Yeah, just follow up on our clinical cancer research paper. We had actually now a grant from the Department of Defense to screen for new drugs for this disease. We have a couple of patients that are xenografted. We're doing this small molecule screening in vitro with organoids. And I think this is a very, very sad disease, but it's really a terrible beast, because we are learning now that these fusion proteins, and I think Gabriel probably has seen the same, they're not the same. It's not just TFE3, it's really the breaking point, the partners. So the biology of this tumor is not just one biology. And that's, I think, it puts a lot of challenges, how we're gonna find a therapeutic target. So we hope we're doing this small molecule screening of a couple of thousand FDA-approved drugs for some of these fusion partners, fusion proteins. So hopefully we'll get some lead compounds in our, as you mentioned about the PI3 kinase mTOR inhibition, perhaps in TFE3 SVP3 fusion protein. We'll see. In vitro, we see some activity with gemcitabine. We need to learn why some tumors actually are more sensitive to gemcitabine. But we believe also it's a tumor metabolic disease like all kidney cancer is, right? So we have we're actually generated some data with the dietary restriction, with dietary modification, how the diet, we work on protein restriction. And we believe that some of these TFE3 driven tumors may be sensitive also to, as an adjuvant tool to protein restriction. So thank you.
Roberto. I think in the interest of time, we're about halfway in our program here. We're now at the top of the hour. We have another 30 minutes. We can go a little bit over, but I think I want to make sure we cover all other aspects of all the different diverse subtypes that are important. And many of the patients and their caregivers are also on the watching us tonight. So I think it's important now to go from the less than 1% collecting duct and the 1.5% in adults of translocation to the one that is most common among all the variant histologies of RCC. I want to turn to you, Ram. You and your colleagues at the NCI have been championing the work in papillary RCC. I think it's important if you can briefly give us also the state-of-the-art knowledge about the biology, what we know about papillary RCC now, and beyond MET, which is obviously the most recognizable of the molecular alterations of papillary. What other targets have you discovered that are maybe actionable, that are exploitable from therapeutic standpoint? Ram,
Thank you so much, Nizar. First of all, thank you for setting up this wonderful session and for inviting me to speak here. I'll try to be very, very brief and try to make some key points that I think are important to consider when we look at patients with papillary kidney cancer. I think most of you are familiar when Marston or I begin a talk, we always start off by saying kidney cancer isn't one disease, and we've done it for years, and I think everybody recognizes that now. I think I can say the same for papillary kidney cancer. I think it's a very heterogeneous group of diseases, all characterized by the presence of papillary features on histopathology. As you all know, it's very broadly classified into type 1 and type 2 tumors, and I think it's been well recognized for years that that doesn't tell the whole story. Maria Marino, ever since I've known her, has said she doesn't like the term type 2 papillary kidney cancer because it's really a diagnosis of exclusion. Anything that's papillary that doesn't include type 1 often gets put in the bracket, and she has always discerned subcategories even at a histologic level. That's, I think, been further borne out by the TCGA study, where distinct molecular signatures have further been able to subclassify what we traditionally call type 2 papillary kidney cancer or non-type 1 papillary kidney cancer into additional subtypes. The point I'm really trying to make is I don't think we should approach papillary kidney cancer as one disease. And I think that's been a recurring theme here today. It's true of translocation RCC. It's true of papillary kidney cancer, and I'm sure as we hear of some other subtypes of kidney cancer as well. Where are we today with treatment of papillary kidney cancer? I think we have come some distance. I'm not saying that we're done with this disease. I won't pretend that we know how to treat everybody with papillary kidney cancer, but we do think checkpoint inhibitors now have some efficacy in patients with papillary kidney cancer. MET inhibitors do have some activity in a subgroup of patients with papillary kidney cancer. I want to compliment Tony and colleagues for doing a very well-designed biomarker-based randomized study, which is really, really, really difficult to do in this field. But kudos to them for doing this study. And I think what we've learned from several studies with MET in this field, starting with furitinib and going on to some smaller studies with crizotinib, capmatinib, and then savolitinib, is that there is a subgroup that does respond. What that subgroup is, I think, needs to be further defined and in more certain terms. I believe most of the patients who respond to MET inhibitors are probably those who carry a MET mutation. There are patients without MET mutations that will respond, but I think one of the things that I may have, at least in retrospect, think differently about the SAVOR study is that by including everybody with an additional chromosome 7, we may have somewhat diluted the population that may actually be sensitive to MET inhibitors. And I think that there's a lot of, I think, scope for studying that further. So I don't think the MET story is completely done. I think we just need to refine understanding of what patients MET inhibitors are most likely to work in. I will then move on, very briefly to talk about a topic that's very close to my heart, and that's the combination of bevacizumab and erlotinib, which we really designed several years ago to try and target patients with fumarate hydratase deficient kidney cancer. I don't have time to go into the biology and why we exactly picked those. Part of it was serendipity, and part of it I think was science. But regardless, as you're probably aware, we designed this phase 2 study to look at this combination both in patients with FH deficient papillary RCC or HLRCC, as well as an independent cohort that we accrued in parallel to look at the efficacy in the more unselected sporadic papillary kidney cancer population. We are very, very encouraged by what we're seeing in patients with FH deficient kidney cancer. The response rates to bev and erlotinib in that population are around 70% or thereabout. The number of patients on the study was 43, not hundreds of patients, but for a rare disease like HLRCC, I think it's a reasonable number. The median PFS for the FH deficient group was around 21 months. Again, most of the patients who responded had very, very durable responses. We also saw that of the 30% or so patients who didn't have an objective response, the vast majority had stable disease. And in many of these patients who had stable disease, the stable disease was durable as well. We've seen patients who've had stable disease for 4 or 5 years sometimes. In the sporadic papillary kidney cancer group, the response rates were less, around 35%. But we still did see some reasonable responses. I'm not surprised that the response rate was less. We took everybody who was not FH but had papillary kidney cancer on that study. And given the vast heterogeneity that exists within this group, it's not surprising that some patients did and some patients did not respond. We did notice that responders were often able to enjoy their responses for fair amounts of time. So, median duration of response in sporadic patients who actually enjoyed a PR was around 19 months. So not everybody responds, but those who respond often tend to do so for prolonged periods. Where do we go from here? I think I'm very comfortable saying that if I saw a patient today with fumarate hydratase deficient kidney cancer, I'd probably consider bev-erlotinib as a treatment option for those patients. I think we need a little bit more work with the sporadic patients. We are in the process of trying to characterize responders at a molecular level to see if we can gain some insights into who the patients are that actually respond. And I think a little bit of work needs to be done before I can tell you anything meaningful about those efforts. I'm going to stop there in the interest of time and certainly deal with any questions that might arise at the end of the session.
Ram, thank you. Obviously, I think the bev-erlotinib phase 2 data with 72% response rate, as you mentioned, in the FH, in the LH RCC, the hereditary leiomyoma RCC is, I think, impressive, and I think this should be approved by insurance and should be the standard of care now for the treatment of patients with hereditary leiomyoma RCC. There's no question about it. My question to you is about, have you seen patients who have sporadic, because we've seen few at MD Anderson patients with sporadic fumarate hydratase deficient tumors that are not, they're sporadic, they're not HLRCC. What is your experience with these? Do they respond equally well, and how common is this? And then the other question is, beyond bev-erlotinib, from the work that you and your colleagues at the NCI have done, what other targets do you think are relevant, are exploitable? Is NRF2 a target therapeutically, or some of these other molecular alterations that you see sometimes with the broad spectrum of papillary type 2? I mean, obviously, I think there is MET inhibitors there, and mostly the type 1 and some of the type 2. And then, of course, the the hereditary RCC. But then I think between those two groups, you have a lot of papillary type 2 that really don't respond well. And I think what can we tell these patients, and what trials are there being developed for those patients who don't, fall into the MET-driven or the hereditary LRCC?
So thank you, Nizar, for those questions. I'll try and answer the first one first because I think it's easier to answer. I don't see a lot of patients with somatic on the FH mutations. They're certainly out there, but they're much rarer than even the FH population. Part of the problem is maybe we're not testing for FH alterations in patients who don't have the syndromic manifestations of HLRCC, and if we did more routinely test for FH, we may see more of those. I do see them occasionally. I don't think the numbers are large enough for me to confidently say one way or another whether they're going to respond just the way patients with germline FH mutations respond. I have seen patients responding to bevacizumab, and I have seen patients who have not responded to bevacizumab. Just not a large enough experience in my hands to make a confident statement about whether or not these patients are sensitive, and if so, whether their sensitivity and response compares with that of the HLRCC patients. I'd be happy to get together with others in the group to see if we can pool our patients and try to see if there are enough patients amongst all of us to try and make a story out of this. The second question is much harder. I think with type 1, I think we all understand that MET's part of the story. The vast majority of patients with type 1 don't have MET mutations. And in the absence of MET mutations, as I said before, I think only a minority of patients are likely to respond to MET inhibitors. So what else do these patients respond to? We have tried to take a fairly broad approach based a little bit on the expertise that's available within our group. Len Nickers, as you know, is an expert on HSP90 biology, and he had shown in lung cancer and gastric cancer models that you can overcome resistance to MET inhibitors in those tumor types that are thought to be at least partially driven by MET with HSP90 inhibitors. And they showed this in a very elegant paper in Clinical Cancer Research a few years ago. And we also have some data suggesting that using a very broadly targeted agent like an HSP90 inhibitor, we can overcome resistance in type 1 papillary kidney cancer cell lines to MET inhibitors. The trick really is, how do we really translate this into the clinic? HSP90 inhibitors, I don't think, are a viable option in the clinic. So we are in the process of trying to see what exactly it is that HSP90 inhibitors do that really confer the sensitivity to type 1 papillary kidney cancer. We're not there yet, but stay tuned, and hopefully in the next few months to years, we'll have a little better understanding of what we may be able to do better to target type 1 papillary kidney cancer. With type 2, I think there's so much heterogeneity. It's hard for me to point to one agent or one target and say, hey, this is what we should go after. I don't know that genes like NRF2 are directly targetable, but certainly I think something to look at. To date, I can't tell you that I have a great answer for patients that don't already fall into a well-defined genetic bracket that we've made some headway with.
Thank you, Ram. Thank you for this really, again, tour the force here about papillary, an important and common, the second most common tumor among RCC. I'd like to now turn attention to
Nizar.
Just
one thing I want to add, maybe for Ram, based on the work you've done and based on the potential, overexpression and accumulation of HIF, both 1 and 2 in HLRCC, and the role of hydroxylase here, you wonder if the HIF2 inhibitor would be active. And I think they should be tested in HLRCC. I don't know, what's your take on that?
Yeah, I think it's a very good point, Tony. Our belief is at least that the role of HIF2 and HLRCC still is a little up in the air. We certainly see a lot more overexpression of HIF1 than HIF2. Having said that, I think HIF2 bears testing, and I would love to test it. We are actually working with preclinical models at this point to see if we can make a strong case for testing HIF2 alpha inhibitors in this setting. So the moment the drugs are available for testing in this setting clinically, I would love to put this hypothesis to the test in the
because intracellular fumarate really stabilizes HIF.
Correct.
And there will be an inhibition of all these prolyl hydroxylase, making a HIF2 inhibitor quite reasonable to use.
There's also some interesting data from the Yale group. Brian was very actively involved with this before he moved to UCLA, that there is a DNA repair defect signature in both FH and SDH deficient tumors. And so that's another area I think that's worth exploiting. So there are a few leads I think we have for HLRCC. What exactly will bear fruit in the clinic, I think needs to be seen.
I think there are a couple of questions here to you, Ram. Okay, let me see here. So the question here, maybe Deb, you can ask that question to Dr. Srinivasan. I think, will the manufacturer be taking Bev erlotinib through to FDA approval for HLRCC? It would make it easier for patients to access this. I think that's an important question.
Yeah, I think it is. We tried very hard. We spoke with Genentech. Unfortunately, I happen to pick drugs that are fairly late in their in their life cycle. So with the patents expiring, there wasn't a strong interest to develop this regimen and take it to the FDA for approval. I personally have not had any encounter any difficulty getting this combination for patients off protocol on a standard of care basis, and I think incorporation in national guidelines like NCCN may actually make the process even a little easier. But I don't think FDA approval for this regimen is on the cards, unfortunately.
Yeah, I think I'd like to turn attention. Thanks for this, again, wonderful review of papillary, the field. Let's now turn over to Dr. Lisa Henske and Dr. Mehdi Malapur, talking about chromophobe. I think, chromophobe for years, was the RCC subtype that was the most indolent when it is rarely metastatic, very indolent, and before all the therapies came out, patients did very well. But unfortunately, I think it's lagging behind in terms of therapies, especially that it is now well known that chromophobe RCC is a immunologically cold tumor, and the immune checkpoint inhibitors really have produced less than 10% response rate in this disease. So Lisa, turning over to you now, you have a session at the KCRS meeting this year, and you spoke also last year about the pathogenesis of chromophobe. Maybe you can update us about this. And then my question to you is there, can we biologically link your findings, and then you can speak about GGT1 if you like, and other findings from your work, and the fact that these tumors are cold immunologically. How can we, maybe leverage the biology, our understanding of the biology, to turn these tumors into a hot immunologically so that they can respond better to immune checkpoint inhibitors? And then the same thing to you, Mehdi. You can speak about this, but let's start with Lisa. Go ahead, Lisa. So tell us what, from a pathogenesis and biology standpoint, what do we know now about chromophobe, the classical type and the eosinophilic type, and what can we expect from the field in terms of application to therapeutics?
Thank you, Nizar, and thanks everybody. This has been such an amazing session. The biology of these tumors each is just absolutely fascinating. So chromophobes, as most of you know, represent maybe 5% of all sporadic tumors. I became interested in them because of my interests in tuberous sclerosis and Birt-Hogg-Debye syndrome. Maybe shares those interests. In both TSC and BHD, there can be renal cell carcinomas that are chromophobe oncocytic hybrids or just true chromophobes. And it links the biology of chromophobes to these diseases in ways that are really not yet entirely clear, at least to me. Chromophobes also have several other really odd distinctive characteristics. One is the striking accumulation of abnormal appearing mitochondria in many of them, and the loss of entire chromosomes. As I'm sure many of you know, chromosome 1, 2, 6, and several others are also often completely lost in chromophobes. And lastly, they have very few driver mutations compared to clear cell tumors, more similar, I guess, to the translocation tumors. Only about half of them have an identified driver mutation in the TCGA, and those represent primarily P53, P10, and other PI3 kinase pathway alterations. So it's still a bit mysterious exactly what the initiating molecular event is for chromophobes. Some people believe that it's mitochondrial alterations because ND1 and ND5 mutations occur in maybe 15 or so %, perhaps more. So fundamentally, putting everything together, we and others think that the problem revolves around an alteration in cellular response to oxidant stress. There are a few clues to that. One is the abnormal appearing mitochondria, and another is that we have found very low levels of a transpeptidase, a plasma membrane transpeptidase called GGT1, gamma glutamyl transferase 1, in chromophobe cells. It's only about 1% of the level that's present in normal kidney, and we don't see that alteration in clear cell tumors. So when GGT1 is low, cells would theoretically be unable to so-called recycle glutathione, to move it from outside the cell to inside the cell by converting it to a gamma glutamyl amino acid. So that's clearly happening in the chromophobe cells, but surprisingly, they have strikingly high levels of glutathione. And the same is true of oncocytomas, very high levels of glutathione. So it's very, I guess, uncertain right now exactly how that happens, what causes them to have low levels of glutathione recycling. And yet it seems that they are increasing dramatically their synthesis of endogenous glutathione. Our most recent work suggests that this leads to a defect in ferroptosis, programmed cell death, and how, as everyone is interested, how do you take these fundamental biologic features and lead to some type of therapy? For chromophobes, as has been mentioned for many other subtypes, we really need to understand the biology more clearly before we'll be able to have specific therapies. So we're going to do a drug screen at the Harvard Medical School facility with and without GGT1 expression in the one useful cell line we have for chromophobes, which was developed by Marston Linehan and others. And we're also doing single cell RNA sequencing on chromophobe tumors in collaboration with David Brown and funded by a grant I received from the DoD program. We have not yet begun to look at the immunomicroenvironment of the chromophobes, but I think that will be one of the most important outcomes of the single cell analysis, try to understand, as Nizar has already pointed out, why are they immunologically cold? Is that related in some way to this abnormal response to oxidative stress? And can we somehow convert the tumors to become more immunologically active, or can we exploit the oxidative stress abnormalities to lead to targeted therapies? So we're very interested in all of those questions. And I think, there are some themes here with maybe some similarities to the translocations, and that we have a very low number of somatic mutations, and we really like to learn from the other rare subtypes.
Fascinating as always. Thank you, Lisa, for the update on your work, and interested to hear a follow-up hopefully later once you start doing the single cell sequencing and then the drug screen on these on the cell line that you have. We'll be interested to hear more about it maybe in a future meeting. Mehdi, I want to turn to you now. Can you tell us a little bit about what research are you doing on this particular subtype of RCC chromophobe, and maybe you can also chime in on other things in this diverse of rare tumors you can tell us about.
Thank you, Dr. Tannir. What an amazing day! Thank you for organizing this session. I'm having such a great time. I'm seeing some old friends, making new friends as always. So, of course, Lisa elegantly really defined these two subtypes of kidney cancer. My interest really started with Birt-Hogg-Dubé syndrome, predisposing the patients to develop a chromophobe kidney cancer. And we really wanted to understand its disease at the biology, at the biochemistry, at the molecular level. I mean, Bill Kaelin is a classic example. If you want to understand the disease, you need to understand what are the genes involved. In this case, we know the tumor suppressor folliculin, FLCN, is involved. I showed some of this data last year. We took a very neutral stand on this, and in collaboration with my chairman, who's here, Dr. Gennady Braslovsky, we took a 5 years campaign to understand the molecular function of this tumor suppressor. A lot of literature has been published on this, and to be quite honest, and this is not a criticism of my colleagues, and luckily nobody's in here, the field is, we felt at the time, was very confused, very clouded with misinformation. What we have come to understand that this disease is actually is a metabolic, like many different types of kidney cancer, it's a metabolic disease. And we have realized that this tumor suppressor, it's an inhibitor of lactate dehydrogenase A. And in PhD patients, this gene is switched off as a result of mutation, and as a result of this, LDHA is hyperactive. We have utilized, but taking orthogonal approach, we have realized how LDHA is being inhibited by this tumor suppressor. We have designed a peptide, and right now we are evaluating the therapeutic potential of this peptide, obtaining PK/PD. Again, we have access to tissues from patients, thanks to our collaborators with Dr. Braslovsky. And we realized that we are actually pushing forward, we are understanding. But what is even interesting, we have realized that this tumor suppressor is involved in other types of cancers that they're going through this metabolic shift. So the potential therapeutic and understanding of this is not only narrow to this very rare types of syndrome, but goes beyond that. It applies to other types of disease. One last thing I want to mention, some common things that Lisa mentioned. We are realizing that there is a crosstalk between these two pathways, the BHD folliculin and TSC, or angiomyolipoma. We have seen patients, there are many case reports that actually being published that BHD patients actually developing sporadic angiomyolipoma. And at the molecular level, we have realized that in the heart of this, as Ram mentioned earlier, heat shock protein 90 chaperones actually sitting at the hub, at the middle of these two pathways and linking these two pathways. So the take-home message is that we have taken a very neutral point of view with patients in our minds, and we try to understand the crosstalk between these two pathways and how we can actually target these based on many different types of methodologies that we have at our disposal.
Thanks, Mehdi. And again, we're approaching the end of the hour here. I'd like to make sure we have time for the other two panelists, Pablo Smisawel and Brian Shook. because I think, the other two important questions is renal medullary carcinoma. I think it's a very important disease that has been invisible for years. And hopefully now Pavlos is trying to make it more visible. Pavlos, you're on. Can you take us quickly through a tour de force of RMC, what we know, the latest? I mean, this is a very devastating RCC type, most virulent cancer of the kidney, and affects, unfortunately, young people, similar to translocation, but predominantly African-American with sickle cell trait. And what have we learned the last 3-4 years, Pavlos? What have you learned, and where is the field going?
Yeah, thank you, Nizar, for inviting me to this wonderful discussion with wonderful colleagues. And thank you for infecting me with your enthusiasm. As I've said many times before about renal medullary carcinoma, I'm doing all of this research and I have this passion because of you. And so, as you very correctly noted, this is a highly, highly aggressive kidney cancer. Renal medullary carcinoma, abbreviated as RMC, afflicts predominantly young individuals of African descent, and it has zero response to the TKIs that we normally give for clear cell RCC. It's the same as giving them water. And we really need to raise awareness for this disease. It has, as you correctly said, been invisible for too long. At MD Anderson, as you know, we nowadays diagnose renal medullary carcinoma 10 times more often than we diagnose collecting duct carcinoma. Now that might be, a reference bias, but it shows, you and I, between ourselves, we see how many now, 1 to 2 new cases of renal medullary carcinoma per month. So it's a disease that actually is a little bit more common than we thought 5 years ago. And it's a disease that clearly needs to be treated early and needs to be treated properly. So raising awareness is crucial, and I'm really grateful to the patient advocates and the organizations that keep popping up now and coming and becoming more and more active throughout the world to raise awareness about this disease amongst the communities and amongst physicians. And this is a global phenomenon because in the US, where we see all of these cases that we see, we have 3 million people with sickle cell traits. And as you mentioned, renal medullary carcinoma is associated with sickle cell trait, or any sickle hemoglobinopathies, really. That's the major risk factor for this disease. But in the world, there are 300 million people with sickle cell trait, 100 times more. So where are all these people? Now that we're raising awareness, as you know, we're hearing about these people. We're hearing about them from Africa. We heard about one case from Nigeria. We're hearing this even from Greece. So it's a global phenomenon. So raising awareness, number one, very important. That will help us find the cases, develop trials, do all of this, and help these patients. And then understand the biology. This is a disease driven by the loss of the extremely powerful tumor suppressor SMARCB1. And as you know, we used to think that was the main characteristic, that it has a simple genome, kind of like malignant rhabdoid tumors, a very aggressive kidney cancer that afflicts mainly very young children. But as we published recently in our paper in Cancer Cell, we found that it's a little bit more complex than that, unfortunately, the story. So renal medullary carcinoma does not have as simple of a genome. It has a lot of copy number alterations. It has very frequent c-MYC gain, 8q gain and c-MYC gains, and it seems to be addicted in many ways to c-MYC. And has other hallmarks that we noted there, like the upregulation of c-Gas sting, a very distinct immune microenvironment. So understanding the biology is key to develop trials. We need to understand how it happens. And one of the things that we postulated a few years ago is that, this may be a disease of infarcts from red blood cell sickling. And whether you have trait or disease, you're still going to have sickling in the medulla because the medulla is such a very hypoxic tissue. And this may explain its unique clinical features of this cancer, like the fact that it occurs 3 times more commonly in the right kidney compared with the left. You don't see that with most other kidney cancers. Some say it may be found in collecting duct, but that might be that those cases were actually RMC. And so we have some clinical trials running, and one of them that we're running at MD Anderson is dedicated to targeting stress-induced responses related to this c-Myc addiction, proteotoxic stress and replication stress that happens because of this upregulation of the c-Myc-induced pathways. And at the same time, doing biopsies, trying to understand resistant mechanisms. None of those things is going to be a silver bullet necessarily. We need to do better. And how can we do better? Also by finding how to best harness the immune system for this deadly disease. And this is also a work in progress. And that's a tissue-rich trial that we're also doing of immunotherapy in this cancer. So these are the key salient points that I would say are very important for RMC and that we need to address now and in the near future.
Thank you, Pavlos. Last but not least, Brian. Brian Shook is with us. Brian, I'd like to turn over to you now. And we know that sarcomatoid is not a separate type or subtype of RCC, but it is present in about 10%, whether it's present with clear cell, present with papillary, with chromophobe, and others. Can you give us an overview of your research as well as the field, our understanding of the transition from the epithelial to the spindle or sarcoma-like sarcomatoid? What biologically we know now about this, and we know very well that those sarcomatoid are inflamed tumors, more aggressive, and fortunately for the clear cell RCC with sarcomatoid, they have a high PD-L1 expression, and they have been responsive, as recent trials with immune checkpoint inhibitors have shown, responsive to the like Nivo-Ipi and other Pembrolizumab, etc., but not so much with the chromophobe when they develop sarcomatoid. Can you glean on for us here the understanding, the biology of what is happening here when patients, when these tumors develop sarcomatoid dedifferentiation? Brian?
Hey, well, thank you guys for staying to the end. So again, as Nizar said, this is a subtype. This should be a subtype, but now it's more of a feature. And that's because we can see sarcomatoid tumors with any type of epithelial element. They do resemble sarcomas. And we didn't understand the biology, whether these were collision tumors, whether these were maybe a subclonal event. I became interested in this about 15 years ago. And when we didn't have these fancy technologies, we really relied on looking at IHC or looking at maybe even pattern of spread. But really the survival, this is a big success story in the field where really survival used to be 4 to 8 months. And patients got conventional chemotherapy due to, they look like sarcomas, we'll treat them like sarcomas. But in the era of the targeted agents, we did a lot of work with staining these tumors. They had an upregulation of some of the mTOR pathway proteins. We also saw that these patients had high VEGF receptor levels. HIF was up, so postulated that they would respond to classic tyrosine kinase inhibitors or mTOR inhibitors, and they did, but the response rates were poor, and patients did improve their prognosis from 4 to 8 months to around maybe 12 to 18 months. We kind of got into this looking at, I had a collection of about 30 tumors I took with me from UCLA to NCI and then to Yale. And when the technology caught up with us, we did exome sequencing of each component. And the goal was to see if there was a sarcomatoid gene. And after about $100,000 spent, we learned a lot. We didn't find there was one sarcomatoid gene. Yossi Schlesinger, who was kind of mentoring me on this project, who was responsible for much of what we know about tyrosine kinases, did consider this an utter failure. But I think we did learn a lot. We were able to prove in a PNAS paper that this is clearly a subclonal event, that there was shared mutations throughout. and there were distinct patterns of sarcomatoid transformation. I think it's challenging because there's not one driver pathway to become a sarcomatoid tumor. You have a pattern of P53, NF2, ARID1A, BAP1, FAT1, a bunch of different genomic drivers. We did see that the mutation burden was higher in the sarcomatoid element versus the clear cell element, but when matched against other non-sarcomatoid tumors that are high grade, really does not look to be that drastically different other than maybe some enrichment. But what is exciting is, you know, in the era of immunotherapy, we have tons of data showing PD-L1 expression is higher. I think Tony's group showed it's not due to PD-L1 amplification, but these tumors are infiltrated, they're inflamed, they have a high amount of, you know, of a cyber sort. You can look and you can see a lot of different enrichment for TILs and other, you know, macrophages, et cetera. And it's remarkable that now the response rate is, you know, 50%, with a complete response rate of, you know, anywhere from 5 to 18%, depending on which combination IO VEGF or IO therapy is given. And then the amazing thing is patients now, median survival might be, you know, 3 to 3.5 years. I think the field is now going to need to figure out, you know, what element of the tumor is still kept alive, and you know, after treatment with these immune checkpoint inhibitors, and do we now go back and look at the genomic drivers of sarcomatoid, or is that element even still alive? And I can tell you that I've had patients who have made it to cytoreductive nephrectomy, and we haven't seen, I'd love to pool series, we haven't seen the sarcomatoid element present anymore. So is that area getting burnt out, and we're now treating the non-sarcomatoid element? Who knows?
Thank you, Brian. Brian, what can we do for patients with chromophobe and sarcomatoid? I mean, obviously chromophobe, you know, may respond to mTOR inhibitors and VEGF RTKIs, but when they are associated with sarcomatoid, they really don't respond well, and it's just heartbreaking. Do you have any insights into what can we do for the chromophobe that is associated with sarcomatoid?
Yeah, I mean, I would say that we don't understand whether the biology is similar in the sarcomatoid transformed chromophobe. I would tell you the pathologists who've looked at these say that they don't have necessarily the same appearance of like, you know, leiomyosarcomatous appearance or malignant fibrous histosarcoma appearance. But the patients who have responded, you know, I know just talking to bugging people like Tony and others, that the sarcomatoid chromophobe are probably the more likely to respond to PD-L1. We've had a couple patients here where they have had no responses, but we have gotten them levantinib and everolimus, and they have had responses. But I think it may, the chromophobe bad ones, the sarcomatoid ones may have, you know, similar, but there's just not much data out there whether they have similar immune infiltration and inflamed tumor. But we have seen a couple of responses to those tumors.
Thanks, Brad. I think we have a question from an audience, one of the fine people here watching us tonight. What advice can be given to patients whose initial pathology is mixed or has not been reviewed by experts? Anybody can answer that question. Would anybody like to answer that? Ram, what is your advice? What advice can be given to patients whose initial pathology is mixed or has not been reviewed by experts? I mean, obviously, we would recommend to have the slides sent to experts to review it. That's the first thing to do, because obviously pathology review is key here before we initiate therapy or recommend any therapy.
So, yeah, I think I agree. I think the first step should be to get the right diagnosis, but if treatment is required in the interim, my tendency is to treat them like clear cell kidney cancer, largely because many of the other subtypes, we don't really know what the best treatment is, bar some exceptions. So while we wait to confirm the diagnosis, I don't think it's unreasonable to treat them with a checkpoint-based therapy. But my preference generally is not to guess and start therapy. If I can help it, I'd like to wait, establish a diagnosis, and then try to approach therapy.
Thanks. On the issue of papillary, was going to ask you, I mean, the Memorial Group has published in JCO in 2016 and recently in Cancer their work with bevacizumab plus everolimus, and they found that some patients with RCC and papillary feature responded to this regimen. What is your take on that, and how in the clinic, since we do not really have a standard of care for any of these varied histologies, is it reasonable to start with bev everolimus if we can get it covered by insurance, or should we give every patient with, say, papillary features your regimen, bev erlotinib?
So I'll try to set my bias aside. So when I see a patient with papillary kidney cancer, the first thing I try to determine is whether the patient is type 1 or non-type 1. Despite the absence of very, very strong evidence one way or another, my bias is to try and take type 1s towards cabozantinib because it's a MET inhibitor that at least in some patients seem to be active. Cabo also seems to have active in all kinds of patients with all kinds of histology. I mean, we've just been talking about how Cabo is active in some patients with TFE3 histology and other histologies. So that's what I do when I think somebody has type 1. That's my first approach. For patients with type 2, if obviously if I think it's HLRCC, I go towards bev erlotinib. If it is not, then I think about either a checkpoint inhibitor or a bev-based regimen, be it bev everolimus or bev erlotinib. I don't have a strong feeling in these patients without a clear subtype diagnosis. We just have some papillary features, whether bev erlotinib is better or bev everolimus is to be preferred. My own experience is that patients tend to tolerate bev erlotinib a little bit better, but then I haven't done a head-to-head comparison, and I'm sure different people may have slightly different opinions on that. Hope that sort of answers the question. I think it's hard to be very precise.
Sure. Along that line, another question came about this particular. The listener asked, what is the difference between papillary cancer and RCC with papillary features? Again, I think you're trying to explain that. You have explained it, that you try to understand what type of, again, with your pathologist working on defining, or really refining the diagnosis, getting more specific about what is the papillary features mean. Is it really papillary type 1 or type 2? Maybe do a molecular analysis, see if it is, has an fumarate hydratase deficiency, to really be able to give the treatment that you think will work best. If it's FH RCC, FH deficient RCC, obviously, I think your regimen of bev erlotinib is the best right now with 72% response rate. I was gonna turn to Brian here since we're talking about PAP, and Brian, you were involved with.
Nizar, can I just add one statement to that, if you don't mind? I still think today in papillary kidney cancer, everything begins and ends with a pathologist. I think having a good pathology read is very, very important. I think you made a point about clear cell with papillary features or tumors with papillary features. When I see diagnosis like, there are papillary features here, I mean, I always want to be 100% certain about what I'm treating, because a lot of patients that get referred to me as papillary kidney cancer have clear cell kidney cancer with some papillae somewhere in the edge of the tumor. I've seen a lot of patients who've been sent to me as papillary kidney cancer who actually turn out to have translocation RCC. And so I think having a good pathologist read these kinds of cases, I think is really, really key. Eventually, I think we'll get to a molecular diagnosis, but unfortunately, we're not there today.
Nizar, can I say one word, please?
Yes.
Go ahead, Tony.
So I mean, this is an amazing panel. I've never seen anything like this. We were up to 50, but I think that the folks in Europe needed to go to sleep. It's 3 a.m. Can't do that. This is torture. But one thing which wasn't highlighted, it wasn't in the original publication. There's a study that Ram and our group led with savolitinib, the initial phase 2 that led to Savoir. And while we showed activity in MET-dependent tumor, there has been some, work there at ESMO that showed when you look at med dependent versus independent and look at histology, type 1 versus non-type 1, and look at grade, etc., the med dependency, you know, was the discriminative factor, not anything else, even med immunohistochemistry. So that brings me to probably a question you're going to ask Brian. I don't know if Monty Pal is here. PAPMET is a very, very, very important study. And we showed with Cabo-San that we can do smaller randomized phase 2 and prove we can be superior to the standard. Here's sunitinib. So I am very excited to see what PAPMET, you know, will show. I wouldn't be surprised.
This was my question to Brian. This was my question to Brian. Brian, you've been working with Monty on the PAPMET. Can you tell us where is, I mean, you're in charge of the translational research for that protocol for all the correlative studies. Can you give us an update on where we are with this trial? And
well, I would tell you that I think there's 1 or 2 more patients that we're getting the data, but the statistician has already looked at the data. Where obviously we can't say, but I think very soon Monty will be informing people. He has a manuscript already kind of written up. The central path review, it took a tremendous effort, but that's all done, and we'll be able to look at that pretty soon. But there's very poor agreement amongst pathologists of what's type 1, type 2, what is a mixed. Getting the tumors from, nationwide is a little bit challenging. I would tell you, even after every patient is submitted, it may take 2 or 3 years to get everything rounded up. We finally received all the tumors, so the draft manuscript will not include a lot of the sequencing. I know, like Savoir, where Tony's able to work and get all those tumors. That's a heroic effort. It's just taken very long to get these.
That's 90% of the work, but
yeah.
Make sure, please, not MET IHC. Even if you get half of the patient and sequence for MET, I think it will be very, very important.
Yeah, we'll probably have 100 tumor sequence. We'll have nanostring. We'll have germline, but it's going to take more time.
A lot of it is a year, right?
Yeah, probably another year. A lot of this has been tracking down a lot of centers that patients are off study, but you need to get those tumors sent in because they weren't sent in initially, or their Buffy code is really actually serum by mistake. It's a lot of tracking down these residual samples.
I want to, obviously, to respect the time and getting late, and you had a long day, everybody. I want to thank the panelists for a wonderful, wonderful, lively discussion, very informative, very up-to-date, very relevant. I hope the people who, the folks who watched, I'm sorry if we can't answer all your questions, but I promise you, I think this will generate interest to come back and do this more elaborately. And again, I want to thank our French colleagues who are brave. Courage, Gabi, and courage, Stéphane, for staying up almost 3 in the morning there. I can't thank you enough for your contributions and for your passion to be with us today. And I want to thank folks who made this happen. Brian Lewis, KidneyCAN, Susan Poteet. I want to thank Deb Behan and Helen Porter as well. Without you, all 4 of you, we couldn't have done this. And so until we meet again, please stay safe, everybody. Stay healthy.
Dr. Tannir.
Brian, go ahead.
Yeah, I apologize. I know, and I really want to say a couple of things real fast. I know the folks in France, I really appreciate you staying up this late, and you can sleep in tomorrow. Real fast, one of the things I see the rich discussion, the passion here. As a patient, Dr. Srinivasan, I was, a mixture, I think, of papillary and clear cell. If you're diagnosed and you don't have any options like the clear cell folks do, it's got to be devastating. I mean, you must face it all the time. It's got to be devastating. So I feel compelled that we've got to do something with the 10 million that's now up to 40, knock on wood, 50 million. I think this group, we figure out a way, use this as sort of a steering committee concept. We figure out how to get some dedicated funding out of the KCRP to go to the subtype variants. You got to have the qualified science, but we peel off a certain percentage and say every year that money is dedicated to that good science that's being written up. So I would like to sort of leave this with KidneyCAN's committed to trying to work with you, Dr. Tannir, and others on this call. Maybe we come together in the next couple of months through another Zoom or something and lay out some groundwork for 2021, because we would like to, amplify what you started today with your leadership. There's just too many people out there that don't have options, and it's unacceptable.
Thank you, Brian, for your kind words and for your encouragement and support. And again, for your help to organize this. If it weren't for you and Susan, and we wouldn't be here. And thanks, Tony, for the co-chairing this second annual KCRS, and for joining us and for your insightful questions. I thank you all again for your contributions and for your time. And until we meet again, please stay safe, you and yours. Good night, everyone.
Good night.
Right.
Bye, everybody.
So long.
See you tomorrow, I hope.
Looks like Gabby is going to be the last to leave.
Okay. I think I'm going to end it for everybody. Everybody, good night.